There are 12 pair of cranial nerves that are named because they arise from the brain and then pass through many of the foramina, or the holes of the bones of the cranium. They are a part of the peripheral nervous system, just as we saw with the spinal nerves. Each nerve has a number, which is designated by a Roman numeral, and a name. The numbers indicate the order from anterior to posterior that the nerves arise from the brain, and the names are going to tell you what that nerve's distribution or function is. There are many mnemonics that you will find to help you remember both the names of the cranial nerves as well as their function. So here you see one example of that. So the second line here are the cranial nerves. Number 1, number 2, number 3, and so on. Olfactory, optic, oculomotor, number 4 being trochlear, and number 12 being the accessory or hypoglossal. So if you look at this mnemonic, of course, you can see that each letter of the cranial nerves is represented by something, a word in the sentence to help you remember that. Now again, there are many of these. You find the one that works for you. You'll also find there are mnemonics that will help you to learn the function of these nerves as well as to whether they are sensory or motor. So some of these cranial nerves are going to carry axons of sensory neurons, so we call those sensory nerves. Others are going to be classified as motor nerves because they contain only axons of motor neurons as they leave the brainstem. Mixed nerves, on the other hand, are going to contain axons of both motor and sensory neurons entering the brainstem and motor neurons leaving the brainstem. So the sensory neurons, of course, are coming into the brain. The motor neurons are exiting. So we'll look at each one of these very briefly. So cranial nerve number 1 is the olfactory nerve. Olfact means to smell, so it is entirely sensory. It contains axons that conduct nerve impulses for olfaction, or the sense of smell. So if you look at this image extending out toward the front of the brain, here we have olfactory nerve, which is cranial nerve number 1. These are the enlarged areas called the olfactory bulbs. Now let's look at an enlargement of that. So here we've got the nerve coming out to the anterior part of the brain. Remember, our frontal bone is here, and then we've got the ethmoid bone that's going to make up this upper part of the nasal cavity with that perpendicular plate coming down that helps to form the septum. But remember, in that ethmoid bone, you saw the crista galli that the meninge is attached to, and on each side of that crista galli was the cribriform plate, which was made up of a bony structure with lots and lots of holes in it. Those holes are where the little fibers from these olfactory bulbs extend down into the nasal mucosa. So here we've got the cribriform plate of the ethmoid bone. Here's the olfactory bulb that's sticking out there and sitting in that cribriform plate, and then the little nerve fibers going down to innervate the nasal mucosa. So we detect odors or smells because they're dissolved. They are chemicals that dissolve in the mucus of the nose. So remember, we've got a mucous membrane that lines our nasal cavity. Those chemicals dissolve in that mucus, and they're detected by olfactory receptors in that nasal mucosa, and then that stimulus is sent through the nerve pathway to the brain, and we process that and realize, oh, I know that smell. That's the smell of Mom's cookies baking in the kitchen. How do we know that? Because there are areas in the brain that store those memories. A clinical connection with this is a condition where we lose the sense of smell, and that is known as anosmia. So it can result from infections of the nasal mucosa, head injuries that may do some damage to that cribriform plate, and then of course the nerve fibers that extend through there are going to be cut, or they're going to be injured, so that bone is fractured, and of course the little tiny nerve fibers that run through it. Anything that causes lesions along the olfactory pathway in the brain, or infections such as meningitis, or things that we do to ourselves such as smoking or cocaine use can destroy those nerve fibers and the olfactory membranes. Cranial nerve number 2 is the optic nerve. It is entirely sensory. It contains axons that conduct nerve impulses for vision. The optic nerve passes through the optic foramen, one of those holes in the skull, remember? And posterior to the eyeball, the two optic nerves cross over and form the optic chiasm or chiasma. So here you can see this optic nerve has been cut off. Here you have the optic nerve going all the way out to the eyeball. So where those optic nerves come back in from the eyeballs, part of those axons from each eye cross over to the opposite side, and part of those axons remain on the same side. Those nerve fibers then are going to run to the occipital lobe of the brain, where we process our special sense of vision. Fractures to the orbit, brain lesions, damage along the visual pathway, or diseases of the nervous system such as MS, pituitary gland tumors, which can compress on the optic nerve because the pituitary gland is going to sit right here. Remember, that's in the sella turcica. So pituitary tumors or cerebral aneurysms, where the blood vessels in the brain enlarge due to a weakening within the walls, can press on those optic nerves and result in the visual fields being defective and the loss of visual acuity. Blindness due to a defect or loss of the vision in one or both eyes is called anopia. Cranial nerve number 3 is the oculomotor nerve. Now look how descriptive that word is. Oculomotor, movement of the eye. So cranial nerve number 3 is going to have somatic fibers that are going to help to move the eyeball and the upper eyelid, and autonomic fibers that are going to help to adjust or constrict the pupil to help us with accommodation and being able to focus on things that are differing distances away from the eyeball. Damage to the oculomotor nerve can cause strabismus, which is a condition where both eyes don't focus on the same object, and that results in one eye or both eyes maybe turning inward or outward, what we commonly call cross eyes. Can also result in ptosis, or a drooping of the upper eyelid, dilation of the pupil, movement of the eyeball downward and outward toward the damaged side, or loss of accommodation for near vision, and diplopia. Ooh, wow, that one didn't come out well. Diplopia, D-I-P-L-O-P-I-A, which is what we commonly call double vision. The trochlear nerve, number 4, is also motor and somatic, and it is the smallest of the 12 cranial nerves. The axons of this nerve help to move the eyeball, along with, of course, cranial nerve number 3, the oculomotor. Damage to this nerve can also result in strabismus, cross-eyed, and diplopia, double vision. The trigeminal nerve, cranial nerve number 4, is the largest of the cranial nerves. It has 3 branches, the ophthalmic, the maxillary, and the mandibular nerve. The trigeminal nerve is a mixed nerve in that it has both motor and sensory functions. The motor functions help us to chew and helps to control some of the muscles within the middle ear. The sensory functions are going to be associated with touch and pain and temperature sensations from areas of the scalp and the face and the oral cavity, including a part of the tongue and the teeth as well. The trigeminal nerve is often associated with pain in many different places throughout the face and the cranium. So neuralgia, or pain, relayed through one or more of the branches of the trigeminal nerve, can be caused by conditions such as inflammation or lesions. When we have that, it's called trigeminal neuralgia or tic douloureux. So, trigeminal neuralgia, much easier, right? This is a sharp, cutting, or tearing pain that lasts for a few seconds to a minute and can be caused by anything that presses on the trigeminal nerve or its branches. It occurs in people usually over the age of 60 and can be the first sign of diseases such as MS or diabetes, perhaps a lack of vitamin B12, or damage to the nerve. Injury of the mandibular nerve can cause paralysis of the chewing muscles and a loss of the sensations of touch, temperature, and proprioception, or the perception of space and position of the lower part of the face. So the maxillary and the mandibular nerves are also targets for the dentist. If you wonder what they're doing when they put that needle in there and they're digging around and feels like they're moving all throughout your mouth, they're trying to get as close as they can to those branches of the maxillary and the mandibular nerve. The closer they get to where those come through the mandibular and the mental foramen, the more likely they are to be able to deaden more of that area of the mouth before dental work. The abducens nerve is completely motor, and it helps to move the eyeballs. It's named because nerve impulses cause abduction, or lateral rotation of the eyeball. With damage to the abducens nerve, the affected eyeball can't move laterally beyond the midpoint, and the eyeball is usually directed medially. So this also, like we saw with the trochlear and the oculomotor, can lead to strabismus and diplopia, cross-eyed, and double vision. The facial nerve is cranial nerve number 7. It is a mixed cranial nerve. It conveys taste from the anterior 2/3 of the tongue, as well as touch, pain, and thermal or temperature sensations from the skin in the external ear canal. It also helps to control the muscles of facial expression and some of the middle ear muscles, and promotes the secretion of tears and saliva. Damage to the facial nerve due to conditions such as a viral infection like shingles or a bacterial infection, Lyme disease, can cause Bell's palsy, which is a paralysis of the facial muscles. It can also result in a loss of taste, decreased secretion of saliva, and the loss of the ability to close the eyes, even when you're asleep. The nerve can also be damaged by trauma, tumors, and stroke. Cranial nerve number 8, the vestibulocochlear nerve, was formerly known as the auditory or acoustic nerve. It has 2 branches, the vestibular branch, which carries impulses for balance and equilibrium, and the cochlear branch, which is going to be responsible for carrying impulses for hearing. Injury to the vestibular branch of the nerve can cause vertigo or feeling like you or your environment is rotating. Also can cause muscles to contract in an incoordinated fashion, and can cause involuntary rapid movement of the eyeball. Injury to the cochlear branch can cause tinnitus, or what we commonly call ringing in the ears, or deafness. The vestibulocochlear nerve may be injured as a result of things such as car accidents or other trauma, lesions, and middle ear infection. Cranial nerve number 9 is the glossopharyngeal nerve. Because it has so many functions, there's another slide that has all of that on there for you. But in this image, you can see the branches from the glossopharyngeal nerve are going to be associated here with a salivary gland, here with the oral cavity, and here with a part of the esophagus or the pharynx prior to the esophagus that is going to be associated with the act of swallowing. So with all that said, what does it do? Well, the glossopharyngeal nerve conveys taste from the posterior 1/3 of the tongue, proprioception from some of the swallowing muscles, touch, pain, and temperature sensations from the skin of the external ear and upper pharynx, monitors blood pressure and oxygen and CO2, carbon dioxide in the blood, aids in swallowing, and helps to promote the secretion of saliva. Injury to the glossopharyngeal nerve causes dysphagia or difficulty in swallowing, reduced secretion of saliva, loss of sensation in the throat, and also perhaps a loss of the sensation of taste. Of course, as with most of the other causes that we've seen for loss of function of the cranial nerves, the most common cause for this is the result of an injury, such as a trauma or lesions that may occur. The vagus nerve, or cranial nerve number 10, is a mixed cranial nerve, and as you can see in this particular image, there's a lot of the body that's going to be associated with the vagus nerve. This is one of those you're going to hear a lot about as we continue to talk throughout this semester and the next. So the vagus nerve is, remember, a mixed nerve. Vagus is named because of vagrant or wandering. So this nerve derives its name from its wide distribution. Sensory axons in the vagus nerve are going to arise from the skin of the external ear for touch, pain, and temperature sensations, a few taste buds in the epiglottis and the pharynx, and proprioceptors in the muscles of the neck and the throat. Sensory axons also come from baroreceptors or pressure receptors in the carotid arteries and chemoreceptors in the carotid and aortic arteries. The majority of the sensory neurons, though, come from visceral sensory receptors. Remember, viscera means organ. So the visceral receptors are going to be are found in most of the organs of the thoracic and abdominal cavities. These are going to convey sensations such as hunger or fullness or discomfort or pain from these organs. In addition to these sensory functions, the vagus nerve is going to be responsible for helping us to swallow and to produce sounds through the larynx in what we commonly call the voice box, and also the action of coughing. And then autonomic motor functions of the gastrointestinal tract, increasing the contraction of the muscles in the gastrointestinal tract and secretion of hormones and other chemical messengers that are going to play a part of the digestive system, constriction of the respiratory passageways, and to decrease heart rate. The vagus nerve, again, is one that we'll hear quite a bit about as we continue to talk. Injuries to the vagus nerve can cause vagal neuropathy or interruption of sensations from many of the organs in the thoracic and abdominal cavities. It can also cause a difficulty in swallowing or tachycardia, which is an increased heart rate. The accessory nerve, cranial nerve number 11, is a motor nerve that is primarily responsible for movement of the head and the pectoral girdle. If the accessory nerve is damaged, the result can be paralysis of the sternocleidomastoid and trapezius muscles. So here you can see the trapezius. That's going to be one of the large muscles that covers the shoulder, or covers a part of the shoulder and extends down into the back. And here you have the sternocleidomastoid muscle. So you can see the branches of the accessory nerve coming out to supply those two muscles. So if that muscle is damaged, then paralysis of those muscles can occur, and then the person would be unable to raise their shoulders and have difficulty turning their head. And finally, cranial nerve number 12 is the hypoglossal. Hypo means below, and glossal refers to tongue. So you can see the branches of this nerve supplying many of the muscles of the mouth. So this is a motor nerve where you have axons that are going to be used in the nerves that help to produce speech and to move food around the mouth in the process of chewing, and also to help us be able to swallow. So injury to the hypoglossal nerve can result in a difficulty in chewing, obviously, difficulty in speaking or swallowing. The tongue may curl to the affected side, and that particular side may atrophy or lose muscle tone. And again, as we saw with many of the other cranial nerves, damage may occur from the result of an injury, a traumatic injury, lesions, stroke, ALS, or infections in the brainstem.